Welcome. My name is Don Frush and I'm a pediatric radiologist, and it is my pleasure to talk to you today a little bit about approaches to radiation dose reduction in pediatric CT. We have to remember as I go through this that CT is an extremely valuable modality. It's life-saving and helps with management strategies every day in practices across the country. Here's an example of a 16-year-old in a motor vehicle collision. Came in with some respiratory distress. As you can see, this is because the liver is in the right hemithorax, and the arrow outlines the diaphragm that's actually ruptured. It allowed the decision to go to the operating room and to fix this significant injury emergently. There are two articles I'd like to outline here, and these would be references if you want to know more information on general pediatric dose management strategies. One by Keith Strauss, and a second that came out this fall in the through the ICRP. We have to remember, too, as we talk about dose reduction, that we need to consider image quality. There has to be a balance between these two, because if we reduce dose too much, there could be significant compromise in image quality. So we need to be mindful of both of those things as we go through and discuss various strategies. So here you see listed some general suggestions. Always, is CT the right modality? Does it need to be done now, or should we consider other modalities that don't use ionizing radiation, for example, ultrasound or MRI? Patient preparation is extremely important. If the patient moves during an examination, even if you're using relatively low dose techniques, then it may have to be repeated, and that exposure, while mindful of radiation dose reduction, will be excessive. Various parameters can be adjusted, and I will touch on the major ones here of tube current and kilovoltage, and these need to be adjusted based on the following that are listed here. The size of the child, the region scan, the indication, and also we need to avoid and modify multiphase examinations in children. Unlike adults, these should be justified in most cases. And in our practice, and I think in most children's hospitals, the use of multiphase examinations is less than 5% for body imaging overall. And another strategy is to limit coverage. You don't want to scan more of an area than you need to. So in general, lower or relatively lower dose pediatric MDCT can result from large abnormalities or high contrast regions such as the lungs or the bones, or when you're doing CT angiography. And by lower dose techniques, I mean decreasing the tube current, or MA, and decreasing the peak kilovoltage, or KVP. I want to step back a minute and go back over patient preparation, because this is something that is, I think, often overlooked. And again, if you don't do this correctly, you will not target the right area, you won't get the appropriate enhancement, the child may move, and again, all of that radiation that was used is potentially wasted. So understand the indications and the anatomy. Is sedation needed? And determine if there are going to be extrinsic or intrinsic devices or support apparatus that are potentially going to affect study quality. Again, the quality part of dose reduction. Here's an example of a gated cardiac CT that we neglected to remove one of the cardiac monitors, and resulted in significant streak artifact through the lower chest and particularly the heart. Here's another example of a child that had had a barium study for abdominal pain. They thought that he had had appendicitis. Subsequently, and this may have been a day or two later, this was an outside institution, performed a CT examination, and these images show the streak artifact from barium, virtually rendering this examination non-diagnostic. It doesn't matter how much radiation is used in this case. It wasn't the appropriate patient preparation. This should have been detected on the topogram, and that scan stopped. Another example, this was a child with suspected sequestration on a chest x-ray. We were doing a CT angiographic study, and as you can see from these four images, there's blurring and haziness, and the contrast enhancement is relatively poor. I'm going to show you four images at the exact same level for a study repeated the next day with appropriate sedation and appropriate enhancement. And you can see very clearly on that lower right-hand image the origin of the systemic artery here demonstrating the sequestration here. Again, image is at the same level. By properly addressing patient preparation, this scan then was optimally performed. So let's look at some of the adjustments that I talked about, the impact of tube current and KVP changes. Tube current. When you decrease the tube current, you increase image noise. This is a child that has appendicitis. You can see in the right lower quadrant there's a thickened appendix. If we decrease the tube current by 25%, and we can do this in our laboratory by adding noise to the image, the patient doesn't need to get scanned twice, you can see that that diagnosis could still be made at about a decrease of 80 MA. However, if you go down to a 75% reduction, 1/4 the level of tube current, I think we all agree this is a little more challenging here in terms of our diagnostic capability, or at least our confidence in that. So remember, tube current, decreased tube current, increased noise. Here's an example of a low tube current examination for a pectus deformity, just 40 MAS. This is a very low dose examination. We don't need fine detail. All we need to do is take some measurements of what the sternal relationship is to the spine, the medial-lateral dimensions, and of course do a survey of the lungs and soft tissues. Here is again the paradigm that I described earlier, where we can add image noise to a study. This is a pediatric patient with a kidney stone, and you can see at 130 MAS that stone in the right kidney, but it's also evident at 40 MAS and at 20 MAS. By adding noise to this image, we are confident now that we can decrease our dose for kidney stone protocols across the pediatric population by up to a factor of 6. So lower MA, higher image noise. It needs to be indication specific. We may not want to decrease the noise as much looking for appendicitis, but for kidney stones, which are very bright high contrast lesions, it may be perfectly reasonable to do that degree of change. Moving on to KVP, especially in small children. When you decrease the peak kilovoltage, you decrease the radiation exposure, the radiation dose, you increase image contrast, and by using a lower KVP in children, 80 or 100, even 70, some manufacturers now have 70 KVP options, you can substantially decrease the dose, because decreases in KVP are exponential versus decrease in MA, which are linear decreases in dose. So by lowering the KVP, especially with a potential high contrast decision process, it's a win-win situation. Now I'd like to show you here what decreases in KVP do to image contrast. There are 4 phantoms on the CT scanner filled with various concentrations of contrast, and notice what happens when we decrease the tube current, okay? The tube current increases the noise. We went down to 10 MAS. Now let's go back to 100 MAS and 120 kV, decrease that. Look what happens to image contrast. So the contrast goes up. The noise also goes up. That is an effect of decreasing the kV. But look how much more we gain by going down in kV in terms of going up in contrast. If we go up in KVP, watch the 2 center cylinders there, see our contrast goes down. We have a less noisy image, but that is at the expense of decreased KVP. So here's an example of a CT angiogram targeting the pulmonary arteries. This child had had an aortic arch reconstruction. We were looking at the pulmonary arteries, really nicely depicted here. Good image quality, 50 MAS, relatively low, at 80 KVP and a pitch. This is less than a normal chest CT in this age would be. We were specifically trying to decrease the dose to optimize the contrast enhancement. When multi-phase examinations need to be done, you need to address what information do you need from each phase. This was a child that had an ultrasound that showed a cystic lesion in the lower pole of the left kidney. The urologist wanted a CT examination to fully delineate this before going to the operating room. So we did a multi-phase examination to see if in fact it was a cyst, and we did a low-dose pre-contrast study, a standard dose nephrographic phase, upper right-hand image, and then a very low dose delayed image just to see if the cystic area filled, to see if it was a parapelvic diverticulum, a pelvic diverticulum, and it did not fill. And we got information that it was a cyst. And so we did this in about 1.5 times the normal exposure or normal dose estimate that would have resulted from this examination. And in fact, we got 3 phases of information. And on coronal reconstructions, I think you can nicely see images displayed here from the nephrographic phase. This ended up being a somewhat unusual regional multicystic dysplastic kidney. It did not need to go to the operating room. These regress on their own, and so we got very useful information, and we're able to target the multiphase examination. Remember, contrast administration is important. We're talking about the quality aspect here, and in some situations you may need to do dual phase and pay attention very carefully to what you're looking for and when optimal enhancement will happen. Early enhancement on this insulinoma in the pancreas identified this lesion. If we had simply done a portal venous examination, it would not have been evident or obvious by any means. So in the next 5 minutes or so, what are some of the general CT dose reduction technologies? And they're listed here: tube current modulation, shielding, dual source CT. And I won't touch on all of these, but I just want to give you an illustration of what some of these strategies are and approaches are to general reduction in dose. I think you're all familiar with tube current modulation, a form of automatic exposure control that will reduce the dose depending on the axial dimensions and also depending on the overall density of tissues in the Z plane here. But I want to make a point, and that is children's acceptable noise may be quite different from adults. This is an adult with a pancreatitis, and you can see that the Hounsfield units here taken, they averaged about 18 to 20 Hounsfield units. But in a child that had liver lesions on 2 separate scans, you can see the image quality varies significantly with a lower noise. 5.9 is a less noisy image versus a 12.8 standard deviation Hounsfield unit, which is a more noisy image. And you cannot see the subtle lesion and the anterior part of the liver on the somewhat noisier images. Now remember, this noise measurement was less than what we accept with adults, which might be 16, 18, 20 Hounsfield units. The point is, in small children and young children, we tolerate less noise, and so examination should be set up to have a slightly less noisy examination in that age group versus the older age group, that is adolescent populations. And here simply illustrated is our chart where the noise index on the GE scanner, which is a way that the scanner uses tube current modulation, is slightly higher for chest CT. We don't need quite the same spatial resolution, and slightly higher as you get older. It is the lowest. We accept less noise in the younger ages, as you can see from the noise indices here, for abdomen scanning. Now, the use of breast shields is debated. Many radiologists in the United States still use these. It's important to say you can do this through several reduction strategies, including decreasing the tube current. But I want to say it's not a bad technique to use breast shields. It does not increase the radiation dose. An article in Pediatric Radiology, I think, summarized some, at that point in time, debate related to the pros and cons of breast shields. And one of the points about using breast shields is there is a new technology called organ-based dose modulation, where the tube current over 120 degree arc is turned down, and then it's increased through the rest of the scan, the rest of the 360 degree arc here as illustrated, which seems fine. You might reduce the dose over the breasts. And in fact, using a radiosensitive film here, the image on the left is with the tube current modulation on, or the organ-based tube current modulation, and you can see green and light yellow over the anterior part, versus where it's not used on the right, and that has a more homogeneous distribution. You also have to note, though, that over the posterior part of this scan, those doses are increased. So you may be conceivably increasing the dose using organ-based dose modulation to areas in the rib and the spine, the esophagus, etc. We've also found that while this 120 degree arc is a good target for breast tissue, in fact, on that image lower left-hand side, oftentimes women's breast tissue may be outside of that arc, and in fact, if you increase the dose beyond that, you may find that you're actually increasing dose to the breast versus using just a standard protocol versus organ-based dose modulation, or even using breast shields. Iterative reconstruction is a technology that I think you're familiar with, and here's an example. This happens to be from the Siemens scanner of the original scan, and using two different levels of noise suppression. And you can see from the image on the lower right-hand side the improvement in terms of image noise. Now, there are some alterations in texture of this, but these technologies and the major CT vendors all have these technologies here, are really changing the landscape and how we do CT, and probably resulting in dose reductions on the order of 40 to 60% at this point in time. And with full implementation and improved image reconstruction, I think many individuals are targeting 75 to 90% dose reductions compared to what we were doing, say, 5 to 10 years ago. Here's the same child here, original 6 millimeter thick image, applying an iterative reconstruction methodology here, 0.6 millimeter thick. And you can see nicely when we reconstruct a 5 millimeter thick image here is that the image quality is excellent at 1/3 of a routine dose that we would do. And we consider our CT protocols relatively low dose to begin with. And finally, there are other general approaches to CT dose management. I did not touch on all the technical aspects there, but just a few. But these are some other ways that we all collectively need to improve our scanning for children in terms of that balance between dose and image quality. We must cultivate research. We must provide practice guidelines, continue education. For example, through the Alliance for Radiation Safety in Pediatric Imaging, image gently or image wisely for the surgical, for the adult population. And we need to align with organizations as well as with industry and develop safety and quality programs which we can use to target our image quality and make improvements, whether it's through cumulative dose tracking or some other aspect of being able to look at our global practices in our individual practices to improve imaging for children. Thank you very much.